closes in such a way, the perfect alignment of the various steps. We will no scope for regurgitation. That is known as coaptation. The coaptation in the mitral valve is the perfect phenomenon. And there are three. When there are two steps, it inherently three steps cannot be replaced geometrically by two or one step or four steps. You won't get the same effect. So all of them you have to regurgitate. Except the three ones. They are only a damage can give rise to regurgitation. So in aortic regurgitation, in a condition where the coaxium of the valve is not alright for any reason, giving rise to incomplete, inadequate closure of the valve during diastole. So there is actual flow between the aorta and the left ventricle. So what is the pressure in aorta? 120/80. What is the pressure in ventricle? 120/0. So there is a gradient during diastole. If the diastole valve is not closed and there is a gradient, there is a huge gradient, 80 and 0. So there is a chance for the blood to flow back till it reaches peak, which means it's a long phenomenon. It doesn't equalize so far. So if at all there is AR, because of a very bad valve, the AR is going to have a long run. Now coming to the pathophysiology of the AR. What is the time at which we hear the murmur? Again to recapitulate, blood comes to superior cava, inferior cava, right atrium, right ventricle, pulmonary streak, left atrium, left ventricle, aorta. Aorta, it goes further. If aortic valve is not all right, the blood from aorta flows in two directions. That is where we start the pathophysiology. Blood in aorta flows in two directions. Forward as it should, backward as it shouldn't. There is never a backward flow except in aortic incontinence. So blood is actually flowing backward from the left ventricle, from the aorta to the left ventricle. So second sentence of pathophysiology, left ventricle gets blood from two sources. One, left atrium. Two, backflow from aorta. So left ventricle has a tremendously increased volume and blood is going out into the aorta. So aorta will get dash volume of blood, excess volume of blood, and therefore what happens is systolic pressure goes up, systolic blood pressure increases. So why does systolic blood pressure increase? There is more blood going out from the aorta to the aorta to the aorta. So if I repeat, aorta two directional flow taking place, one forward, one back. Why backwards flow? Because there is a gradient, 80 and 0. 80 in the aorta, 0 in the ventricle. Backflow is tremendous, potential. And when the backflow is occurring, it does not respect, because it is outside the heart, it doesn't respect your cardiac cycle. What did we say? First phase asymptotic relaxation, second phase is rapid filling, third phase is slow filling, and fourth phase atrial contraction. That is inside the left ventricle. Where is the flow taking place from? Aorta to left ventricle. Outside. It has no respect for the left ventricle. So what happens? Blood is flowing irrespective of the cardiac cycle. So there is no gap between the second sound and the murmur. Immediately following the second sound is the murmur. You understood? There is no gap. Whereas in mitral stenosis, this is followed because inside the heart there is a gap between the second sound and the murmur. There is no flow during the asymmetric relaxation phase in mitral stenosis. In aortic stenosis, it just doesn't respect that there is a free flowing during the diastole irrespective of the cardiac phase. So the murmur starts immediately after the second sound and therefore known as the EDM or early diastolic murmur. What is early diastolic murmur? That murmur starting early part of diastole without a gap between the second sound and the murmur. What is the mid diastolic murmur? Mitral stenosis. That in the middle part or a little later, just exactly middle, there is a gap between the second sound and the murmur because of the asymmetric relaxation phase. The valves are closed, not yet open, there is no flow. Hence there is no flow during the asymmetric relaxation phase. Hence there is no murmur. Therefore it is called mid diastolic murmur. In the situation of aortic regurgitation, there is a free flow, hence there is a early diastolic murmur, no gap. Okay, understood? Now we go to the next. The blood is coming back into the left ventricle. It is producing a murmur because of the current generated, the abnormal flow, and the flow is occurring during diastole. What is the murmur? Early diastolic murmur. And it is heard best in the aortic area, nerve area. And it is best heard in the patient sitting up, leaning forward, breath held in expiration, and it heard with the diaphragm of the stethoscope with the high pitch sound. Now the reverse of mitral stenosis. Mitral stenosis, you get is the low pitch, is the rumbling diastolic murmur, best heard in the lying down position, left lateral, then breath held in expiration, and with the bell of the stethoscope. Here we are saying reverse. Sitting up, leaning forward, breath held in expiration, and there is a high-pitched diastolic murmur that is heard with the diaphragm. There should be no breathing because they are almost similar intensity. Both are same pitch. So if there is very breathing intensity, you cannot hold it. And here the murmur. This is about the murmur of aortic incompetence. Now, there is backflow. There is a murmur. There is backflow. There is more volume. There is a third artery. So that it produces a third artery. The first sound is not affected. Second sound is affected because usually the disease involves the valve. Second sound is soft or single. Third sound is may be present, and the murmur is early diastolic. These are the auscultatory phenomena of aortic incompetence. If we were to draw, this is the first heart sound. The first heart sound. The second heart sound. This is the next first heart sound. Third heart sound. S2 may be affected because of damage in the valve, and as soon as the S2 is over, or the time of S2 is over, there is a murmur. Because there is a backflow occurring into the. What kind of murmur is this? The long diastolic murmur, early diastolic murmur, but doesn't stop here, it goes on. It is a decrescendo murmur, high pitch, vested in the aortic or up area, and goes on. There is a gap between the last. That can be early diastolic. Doesn't mean nothing is only here, it is longer than. There could be a third heart sound if there is too much of flow that is taking here, and there could be occasionally a murmur in the mitral area. This is the aortic nerve stage. In the mitral area, there may be a murmur. What do you call that murmur? That is known as a Austin-Flynn murmur. Why should there be Austin-Flynn murmur? This backflow that is occurring from the aorta may impinge on one of the valves of the mitral valve apparent. So that doesn't close fully, partially closes, giving rise to a hemodynamically significant mitral stenosis-like effect, giving rise to a mitral area diastolic murmur. So what are the auscultatory features of aortic incompetence? They are: 1. Normal sound, 2. Reduced second sound, early diastolic murmur, gap, decrescendo, there could be a third heart sound, and if it is a very free-flowing, going back to the regurgitation, there may be a systolic murmur, slow murmur in the mitral area, in the aortic area, and in the mitral area there may be Austin-Flynn murmur. These are the features of aortic full-fledged aortic infarction, auscultate. Now come to the pathophysiology. We said this is not a concentric hypertension. Critically analyzed, dilated, 6 phase, 7 phase, but not a concentric. It is not felt like a giving effect. It is on the hyperdilated. That was not very well felt. It is difficult. Now I told you that two sets of clinical features. One is central, one is peripheral. And this is one place where the peripheral features dominate. So there are some peripheral features you should know, some classical peripheral features, a long list of signs. I don't think all of them are needed. But a few of them are needed. One is the neurosync pulse. One is the cortical pulse. Start from there. A collapsing pulse. A pulse that is high volume. Hold it there, elevate the hand above the head. And when you hold it like that, you feel it coming and throbbing against your arm, and it's a pain. The high systolic, suddenly it goes down, low diastolic. Why high systolic? Because increase in the output. Why low diastolic? There is a peripheral vasodilation for the blood to flow forward. All the blood flowing backwards, the person will die. So there is a vacuum suction effect. The peripheral vessels, including capillaries, dilate. Peripheral, all arteries, including capillaries, dilate, trying to suck the blood forward. Say, don't go, find out to go somewhere. You're pulling, like that, all the capillaries and arteries pull the blood, come forward, come to me. But it is going backwards. So to prevent the entire backflow, this arterial dilatation and capillary dilatation, compensated phenomenon, suction pulls the blood forward. Now that is seen as the phenomenon. One being the collapsing, high systolic, low diastolic. Number two, sometimes the vest are also felt in the neck, aortic vest, given in the brachial or a iridium, also felt in the neck. Sometimes you feel a what was in the neck? Yes? It may be dancing carotid, but sometimes there is a combination. What do you call that? What kind of pulse is felt in the neck? Anybody? This variance, it may be having feature of aortic stenosis and incompetence. This variance pulse is felt in two situations. One, a very torrential aortic incompetence. Two, coexistence of aortic stenosis with aortic incompetence. So one, Corrigan or this case. Corrigan was a French physician. The story goes, Corrigan, for reasons not known to anybody, went and appeared for MRCP in UK. In the exam, he was performing well, and he got a case of Corrigan's pulse, and he said, Corrigan's pulse. Casually, the examiner asked, who are you? He said, Corrigan. Which Corrigan? Same Corrigan. Then he said, no, I can't examine you. You pass, you go. The examiner refused to examine him, saying that your level is much more than mine. I don't want to examine you. So, Corrigan's pulse, then there is the Biswarian's pulse. Third is the head nodding, bobbing, known as Beamer-Stein. Pulses in the uvula. Sometimes pulses in the uvula. Important other peripheral sign is the chill sign. BP in the lower limb, BP in the upper limb. BP in the lower limb disproportionately more than BP in the upper limb. That is chill sign. Depending on that, you can grade the severity. Then you got a neurosis murmur. Neurosis murmur is also called a to and fro murmur on the femoral. You keep the stress on the femoral artery, press proximally, you have a systolic murmur. This happens anywhere. In normal people also. If you keep a stress and press proximally, you are producing artificial stenosis, no big deal. But the second thing, that is you press distally and there is a diastolic murmur. It doesn't happen in anyone. Because there is no backflow. Only in aortic incompetence there is a backflow, and if you keep the stress on a femoral, press distally, you can hear a diastolic murmur, telling you that indeed there is a backflow. So that together is known as a neurosis murmur. If you keep the stress on the femoral, you hear pistol short sounds, loud sounds produced during the contracts, the crystal short sound. These are all the features, peripheral features. Sometimes you get a alternate subtraction and dilatation of uvula with every, the pupil with every heartbeat. I had been to Pune recently. For the first time I saw this when a student demonstrated. Very nice to see students demonstrating in MD. He was the only student up to now who was demonstrated that time the alternate constriction and dilatation of pupil with every heartbeat. It is very heartening to see. Nobody can quote that. It was the only one person who was finding that they are not even aware that it was there. So these are the peripheral signs. These are the central signs and peripheral signs. Now what are the causes of aortic incontinence? Aortic stenosis, we gave 5 causes over. One is rheumatic, degenerative, bisphoratic valve, calcific, atherosclerotic, monkey-bug sclerosis, methotrexate. What is methotrexate? Or other similar drugs today use the slow serotonin or reuptake inhibitors. They are similar. It can produce mitral regurgitation, now aortic regurgitation. Mitral regurgitation can be then permanent aortic regurgitation can be transient. So remember, these drugs can sometimes the long run produce vulnerability. These are just a few causes. When you come to aortic incontinence, so many causes. The cause can be in the valve or cause can be in the valve ring. When the valve ring is involved, it can be connected to disorder like Marfan's, Ehlers-Danlos disease, or it may be due to syphilis. Why this is important? All these diseases enlarge the heart, the aortic root dilatation. Produce two things. They produce a loud second sound because above the closure of valve, now there is a low pressure chamber created by dilatation of aorta. In usual aortic incontinence, second sound is muffled, but in this situation, P4, where the aortic root is dilated, there is a low pressure chamber created, and the closure produces a tambour-like increased quality of increased loudness of second sound, known as the tambour-like quality of second sound. Best side is the right side of the sternum. Normally we are accustomed to left side of the sternum. Here, right side of the sternum is better heard. This happens in syphilis. This happens in Marfan's and Ehlers-Danlos because of dilatation of the root of the aorta. Now, these are the causes of dilatation of root. Remaining are valve causes. What are they? Rheumatic, congenital, connected to disorders like ankylosing spondylitis. Then, what are the others? Some syndrome, Noonan syndrome. Then, which are the others? Mucopolysaccharidosis. You would have heard of Hurler, Hunter, She, Morphew. Hurler, commonest is involvement of mitral valve. This is again an entrance question. Hurler, mitral valve. Hunter, Morphew, She, aortic valve is more often involved. In Hurler, mitral valve, then tricuspid valve, then aortic. In Hunter, Morphew and She, aortic valve is more often. This is mucopolysaccharidosis. Others are syphilis. Then of course the degenerative. Then hypertension itself can produce aortic regurgitation. High blood pressure can produce. Calcific aortic stenosis can produce. Bicuspid aortic valve with infected endocarditis can produce. Infected endocarditis due to any etiology can produce aortic incontinence. So these are all important causes of aortic incontinence. Then there is a set of causes called acute AIM. What is that? Acute aortic regurgitation. Infected endocarditis, trauma, dissecting aneurysm, rupture of ulcer or sinus of ulcer, all these produce acute, sudden aortic incontinence. There is a difference between chronic AR, which we discussed, and acute AR. Chronic AR, we said all these things are there, there is LV. There is time for the left ventricle to enlarge, dilate, compensatory phenomena, goes on.